Hello, this is a short presentation to summarise a new pathway between primary healthcare and secondary healthcare to enable direct access ultrasound scan for patients with suspected ovarian cancer. And it's a collaborative project between Nottingham University Hospitals and Greater Nottingham Clinical Commissioning Partnership. It'll be of interest to health professionals, managers and commissioners interested in this new pathway, which is a pilot in the Nottingham City CCG area. The email contacts are available at the end of the presentation. The ovaries are two small organs located in the female pelvis and are crucial for reproductive health. There are around 7,000 cases a year of ovarian cancer. Unfortunately, most of these patients present when the disease is advanced, i.e. when it's spread from the ovaries to the fat from the stomach, called the omentum, and occasionally into the lungs, causing a pleural effusion. This is advanced disease, and around a third of our patients will present via emergency routes. So there's a real clear need to try and detect women at early stages to improve the survival rates for these patients. Unfortunately, the average GPs will see very few cases of ovarian cancer. It's estimated that 1 GP in 5 will see a case each year, and in Nottingham we estimate that per practice of 5,000 patients, there'll be one case every 2 years. There are clear drivers to improve the outcomes for these women, including earlier diagnosis leading to better survival rates. The early detection of women can be used with ultrasound scan, high quality scanning of the ovaries, tumour markers, and importantly, clinical assessment. A combination of these factors can potentially lead to an earlier diagnosis of cancer. There's a need for better experience of care and streamlined pathways for our suspected patients with ovarian cancer into specialist settings. And there's a better need for resource trying to avoid repeat community scans and a streamlined pathway with reduced admin leading to cost effectiveness in the process. The challenge is to try and downstage the disease from advanced ovarian cancer, the picture shown on the left, to early stage or stage 1 to 2 cancer with the cartoon shown on the right. Earlier diagnosis is likely to result in improved survival rates for our patients. The disease is often called the silent killer, but that's not true, as much evidence points towards women accessing healthcare prior to a diagnosis of ovarian cancer. Detecting these patients can be very difficult, but the advice that we give to general practitioners is that the acronym BEAT may be appropriate. BEAT in essence stands for a collection of symptoms that may indicate ovarian cancer, and these are recognised by NICE. B for bloating, persistent abdominal bloating or distension. E for difficulty eating meals, feeling full maybe after 1 or 2 mouthfuls. A for abdominal or pelvic pain that's persistent. And T is trouble with urine or difficulty or urgency in passing urine. So BEAT is the acronym, and these are the symptoms that may, particularly if frequent or persistent, indicate ovarian cancer, and particularly in women over the age of 50. This is the new pathway that we're suggesting. And this will be of relevance to general practitioners. If a patient attends the GP surgery with suspicious gynaecological cancer symptoms, if the 2-week wait criteria is met, i.e. pelvic mass, not obviously fibroids, then the GP should refer the patient on a 2-week wait, as per NICE guidance. We will receive the referral and will allocate appointment in the specialist clinics at NUH or Nottingham University Hospitals within 2 weeks. Very few patients come through this pathway. In the new pathway, if the 2-week wait criteria is not met, but the patient does have suspicious gynaecological cancer symptoms, we're suggesting that the GP order an NUH direct access ultrasound scan and take a CA125. We will see the patient at NUH and she will have a specialist scan by one of our expert sonographers. This will usually be carried out within 1 to 2 weeks. The ultrasound scan will be reported, and if there's a normal or low risk cyst, the patient will be referred back to the GP with the report. This is the novel part of the pathway. If our sonographer detects a high risk cyst, not necessarily a cancer cyst, but a high risk cyst of the ovary that warrants a specialist opinion, then the scanner will alert the specialist team via the 2-week wait office that this patient requires a specialist opinion. The scanner will tell the patient that there is a suspicious ovarian mass and there's a need for an urgent clinical review. The 2-week wait clock starts at this point. Using our hospital systems, this scan, which has been alerted to the target office or RAD alerted, will be reviewed by our clinical team and we will see the patient in the 2-week clinic. This may be within a week. We'll endeavour to see the patient as soon as possible. A letter will be generated by our team, however, to the GP because we will need a 2-week wait referral form. So we'd like the GP to complete the 2-week wait referral process. We'd also like them to contact the patient urgently so that they're aware of the ultrasound scans and the importance of attending the 2-week wait appointment. We still need the context of the patient. That's why the GP needs to complete the 2-week wait referral process so we're aware of any drugs or past medical history that's relevant. In essence, we're streamlining the referral pathway from the time of reporting the cyst as high risk to us seeing the patient in the specialist clinic. This slide is available on request using the email at the end of this presentation, but essentially it is the communication that we plan to send to GPs. March is Ovarian Cancer Awareness Month, and we plan to start the pilot in March 2019. The format will look different, but it essentially reminds the GP about the possible symptoms of ovarian cancer, the BEAT acronym that I mentioned before. It's also important to note that if patients fulfill the 2-week wait criteria, they should be referred on that pathway. And this pathway relates really to those patients who have suspicious symptoms but who do not fulfill the 2-week wait criteria. We're asking our GPs to order a scan using the urgent suspected ovarian cancer NUH ultrasound scan of the pelvis code, which will be on the ICE systems. Taking a CA125 is helpful for us in risk assessing patients. 50% of patients will have normal CA125s in early stage disease. At NUH, we'll carry out a transvaginal scan of the pelvis to look at the uterus and ovaries within 1 to 2 weeks. And as I mentioned before, if there's a potential cancer or high risk ovarian cyst, we'll escalate the findings to the specialist team and we'll see the patient rapidly. This will avoid the patient having to go back to the GP with the report and avoid the GP looking out for the report only to refer the patient back to the hospital. We're very keen on advice and guidance, and we are mindful of the fact that many scan reports will be difficult to interpret, particularly for GPs who lack gynecology skills. So the advice and guidance service is always available and we will respond within 5 days. But our vision, ultimately, is to have a rapid diagnostic pathway for symptomatic women with suspected ovarian cancer, using this more streamlined pathway. This letter is a near final version of the communication that we will send at NUH to GPs once a high-risk ovarian cyst has been detected. It asks the GP to contact the patient so that they're aware of the ultrasound scan results and the importance of attending the target clinics, and also asks them to complete the 2-week wait process. It very much mirrors the process that we have for GPs who access MRI scan for brain. This leaflet will be handed to patients who have a high-risk cyst detected on ultrasound scan by the sonographer, and it stresses the importance and the meaning of the 2-week wait referral system, so patients have an understanding that there may be a risk of cancer. We've produced a narrative for our scanners, and these are examples of the communication that we would have with a patient on scanning a patient with a high-risk cyst. Essentially, the narrative talks about the possibility of a problem, the need to see a specialist team, and the sense of urgency attached to the findings on the scan. Why do we need to change the pathway? Well, in the current pathway, symptomatic patients who need a scan may have a scan in the community. The GP has to begin this process, and there may be a delay, more than 1 or 2 weeks. The results have to be awaited and even chased, and the patient has to return back to the GP surgery if she has a high-risk ovarian cyst, only to be referred on to NUH using probably a 2-week wait pathway. If the ultrasound scan that's been carried out in the community is incomplete or uncertain, then the scan may need to be repeated. In the new pathway, patients who are symptomatic are referred to the NUH service, and they'll have a high-quality ultrasound scan of the pelvis. If a high-risk ovarian cyst is detected, then the patient will be escalated to the specialist team by the sonographer, so there's less administration for the GP. There's potentially less chance of having a repeat scan, better patient experience because patients are managed in a more timely way, but we still need a 2-week wait referral from the GP so that we have the context of the patient, past medical history and any relevant drug history. We hope to begin the pilot in March 2019 to coincide with Ovarian Cancer Awareness Month. If you have any questions, please contact us at this email address, david.nuns@nuh.nhs.uk. Many thanks.